Welcome back to the deep dive. If you know a child or an adolescent dealing with episodic migraine, you know it's just so much more than a bad headache.
Oh, absolutely. It's a chronic, often debilitating illness.
Right. It can completely disrupt their life. We're talking about missed school days, social events, just childhood itself.
It's a quality of life emergency for them. And for years, the real challenge in treating this group, we're talking ages 6 to 17, has been the lack of really targeted preventative medication.
We've seen these incredible breakthroughs for adults.
We have.
Yeah.
But getting that same robust controlled data for the pediatric population, that's just a much slower, more careful process.
Exactly. And that is precisely why we're doing this deep dive today. Our mission is really laser focused on a very specific set of findings from the January 2025 New England Journal of Medicine.
The Fremanezumab data.
Yeah.
Highly anticipated.
Yes. We're going to distill this research for you so you can walk away understanding what this drug is, what this trial actually showed, and maybe most importantly, what we still need to learn.
Well, Fremanezumab has become a bit of a household name in adult migraine care. It's a humanized monoclonal antibody, and its mechanism is, well, it's beautifully specific. It selectively targets CGRP.
Okay, CGRP, calcitonin gene-related peptide. Let's pause there for a second. We've heard that term before, but for someone new to this, why is that such a good target? What is it actually doing?
Think of CGRP as the main messenger that, flips the on switch for a migraine attack.
The ignition switch.
Exactly. When a migraine starts, CGRP is released and it acts on blood vessels and nerves, causing that intense throbbing pain. Fremanezumab is like a highly specific blocker that just intercepts that signal.
So it neutralizes it before the whole cascade can even start.
That's the idea.
Which sounds incredibly targeted, a huge change from some of the older preventative meds. And that brings us to the core issue here, the gap. Why was this study in this specific age range so critical?
Because until now, we had the adult data, but the treatments we were giving to kids were often repurposed drugs.
Like anti-seizure medications, things like that.
Right, or antidepressants. And they often come with pretty significant side effect profiles. Or they were just being used off-label based on adult trials. We really like that gold standard.
A randomized, controlled trial.
The clinical certainty for prevention in the 6 to 17 age group just wasn't there.
So the need was crystal clear. Let's get into the parameters of this study. Who exactly were they looking for?
They set very tight boundaries. Participants had to be between 6 and 17, and, importantly, have a formal diagnosis of episodic migraine.
That distinction is critical, so not chronic migraine.
Not chronic, no. They needed participants who'd had migraines for at least 6 months, but were experiencing 14 or fewer headache days per month.
Okay, so they're intentionally excluding those with 15 or more headache days a month. Why do that? Why focus on the episodic group first?
That's a great question. It's because the chronic population tends to be, well, the most treatment resistant.
So it's a tougher nut to crack.
A much tougher nut. By focusing on the episodic group, they're trying to prove efficacy on a, let's say, less severe population first. It lets them establish a baseline of effect without the confounding variable of extreme treatment resistance. It's a very common and smart approach in these initial pediatric trials.
That makes perfect sense. Okay, so trial logistics. It was a 3-month trial, which seems relatively short.
It is short, yes. It was a randomized assignment, monthly subcutaneous injections, so just under the skin, and a 3-month treatment window.
And a key detail is what the participants were allowed to use for an active migraine attack.
That's right. This is really important. They were allowed to continue using their acute medications like triptans.
I see. So the study wasn't about treating an attack in the moment.
No, not at all. It was focused purely on the drug's effectiveness as a preventative measure.
Okay, let's unpack this next crucial component, the dosing. You can't just give a 6-year-old the same dose as a 17-year-old, especially with an injectable.
Absolutely not. Weight-based dosing was fundamental to the trial's design. The biological reality is that drug distribution and metabolism are just very different in growing children.
So they split them into tiers.
2 weight tiers for the active Fremanezumab group, yes.
And what were those tiers?
Participants weighing less than 45 kilograms, that's roughly 100 pounds, they received the lower 120 milligram dose.
Okay.
And those weighing 45 kilograms or more got the higher 225 milligram dose. It's a very tailored, responsible approach.
Given that split, let's talk numbers. How many kids were actually involved in the final analysis?
The full analysis included 234 participants.
And the split between the groups?
It was pretty even. 123 were assigned to the active Fremanezumab group, and 111 got the placebo.
And within that active group, how did the doses break down?
36 of them received the lower 120 milligram dose, and the majority, 87, got the higher 225 milligram dose. That gave them a statistically robust sample size.
Okay, now we get to the core of it, the efficacy. The primary endpoint was the change from baseline in the average number of migraine days per month. So what was the headline number?
The Fremanezumab group reported an average reduction of 2.5 migraine days per month.
2.5 days. And the placebo group?
The placebo group, which is always, a powerful factor in pediatric studies, reported a reduction of 1.4 migraine days per month.
So the difference between them is 1.1 migraine days.
Correct. 1.1 days.
Now, on paper, to a layperson, 1.1 days might not sound, dramatic. How should we interpret the clinical relevance of that number?
That's the crucial distinction, isn't it? Statistical significance versus clinical relevance. That 1.1 day difference was statistically significant. The p-value was 0.02.
So there's only a 2% chance that difference was just random.
Exactly. We're statistically certain the drug works better than the placebo. Now, it's 1.1 days impressive. You have to remember, that's an average across everyone, including those who didn't respond well.
Ah, okay. So it suggests a subset of individuals saw a much, much better result.
A much more dramatic benefit, yes.
And that subset is exactly what we need to look at next. Because here's where it gets really interesting. Frequency is one thing, but what about the quality of life? Let's talk secondary endpoints, like headache severity and responder rates.
Right. So focusing on severity first, they tracked the number of days per month with headaches of at least moderate severity.
So the days when a child is truly impaired, missing school?
Those are the days. The Fremanezumab group reduced those days by 2.6, compared to a 1.5-day reduction in the placebo group.
So again, we see that difference of about 1.1 days, and that was also statistically robust.
It was, which reinforces that the drug isn't just taking the edge off mild headaches. It's reducing the number of days dominated by truly impairing pain.
And that's really what matters to families.
That's often what clinicians prioritize. But the metric that really tells the story for individual patients is that 50% reduction responder rate. That's the gold standard for preventative treatments.
Okay, so what percentage of these kids saw their monthly migraine days cut in half or even better?
This is, I think, the most compelling result in the whole study. The percentage of participants who hit that 50% or greater reduction was 47.2% in the Fremanezumab group.
Wow, nearly half. Nearly half the kids on the active drug had this life-altering reduction in their migraine burden in just 3 months.
It's a phenomenal clinical response. Now, you have to compare that to the placebo group.
Which was?
27.0%.
Okay, so 27% is not nothing. That's a significant placebo response.
It is, and it highlights a consistent challenge in pediatric trials. The placebo effect is often quite strong in kids. The extra attention, the structure, the hope, it all contributes.
But the difference is still huge, a 20 percentage point difference between the two.
Exactly. The fact that Fremanezumab nearly doubled that robust placebo response, that's what makes this data so powerful. And the p-value of 0.002 reflects that certainty. This is a very robust clinical finding.
That is powerful. But of course, whenever you introduce a new medication, especially a novel injectable like this, to a pediatric population, safety has to be the #1 concern.
Absolutely paramount.
So what did the trial tell us about the adverse event profile?
The overall findings for these 3 months were reassuring. The single most common adverse event specifically linked to the drug was injection site erythema.
Meaning redness or irritation at the injection spot.
Just some local redness, yes. It was reported in 9.8% of participants receiving the drug.
And in the placebo group?
It was also present there, but at a lower rate, 5.4%. Other serious adverse events weren't frequent, which suggests the primary side effect concern, at least in the short term, is about the administration method itself, not some systemic complication.
Okay, so to summarize the researchers' definitive conclusion from this trial.
The overarching conclusion was that among children and adolescents with episodic migraine, Fremanezumab resulted in significantly greater reductions in both migraine days and moderate to severe headache days compared to placebo. The short-term benefit is clear.
Bringing it back to that key finding, nearly half the kids finding a 50% reduction. So what does this all mean for a clinician and a family who are considering this treatment right now?
It means we now have robust, specific evidence for efficacy. That's a major victory. This is a completely new tool in the toolbox, moving away from those older, less targeted drugs.
But there's always a but.
There is. And we have to look directly at the limitations cited in the source material itself.
Which, as we said, is the 3-month duration. Migraine can be a lifelong disease.
And that creates a pretty substantial clinical dilemma. The study is explicit that the chronic nature of this disease demands longer follow-up. We're talking years, not months.
So we need to understand the long-term efficacy and, more importantly, long-term safety.
Exactly. We know it works for 3 months. We don't know the impact of administering this to a growing, developing child over 5 or 10 years.
And that raises a critical question for the medical world. These monoclonal antibodies are powerful, and using them long-term on a pediatric population where everything is still maturing, that's a very different proposition than using it on a fully grown adult.
It is. This is where the debate will now sit. The efficacy data is compelling. It's enough to push for adoption in severe cases, but the drug inhibits CGRP, a peptide that's present all through the body, not just in pain pathways.
So we need to be absolutely certain there are no unexpected developmental consequences from blocking that peptide for years on end.
We do. These findings basically unlock the door, but the longer-term studies will determine if we can safely walk through it for sustained treatment.
That leaves us with a really provocative thought to mull over. The research shows a clear, significant therapeutic gain in the short term, a 90-day window of real relief for a child. Given that chronic pain itself can profoundly impact development, how should the medical community, how should parents weigh that immediate, obvious benefit against the unknown variables of sustained long-term treatment?
It forces us to balance the ethical need to treat suffering now with a cautious need to protect long-term health. The initial data is highly promising, but it really just opens the next phase of the investigation.
Indeed. And we look forward to diving into those extended follow-up trials as soon as they're released. Thank you for joining us for the deep dive.